Psychopharm.
Hey, how's it going? This might be a new series of Don't Be Bored Psychiatric Review. The plan is to do 10 to 15 to 20 or so psychiatry board review questions, and then I'll just add stupid commentary, I guess. I'm going to be working off of the Kaplan and Sadek Study Guide and Self-Examination Review in Psychiatry. I'm going to be using the 8th edition because I don't have money for the 9th edition, and I come from a culture that is stereotypically frugal. And you shouldn't be offended by that because you don't even know what culture I'm from. It could be referring to anything. So let's get to it. Mazel tov. And I guess I'll just keep doing this until Mr. Kaplan or Dr. Kaplan and Dr. Sadek send me a cease and desist letter and sue me, and I'll have even less money. So let's get to it. So I'm going to start with the mood disorder section. I guess that's section 17. I'll read the question. You should probably pause, see what your answer is, and then see what the right answer is, and then learn. So, question number 1. Dysthymic disorder. A, usually begins in adulthood. B, does not respond to antidepressants. C, presents with symptoms of lack of say in life and preoccupation with inadequacy. D, is usually limited to 1 or 2 episodes. Or E, is characteristically marked by psychomotor agitation or psychomotor retardation. So I'm going to jump right into the answer, but like I was saying before, if you want to review with me, pause, pick your answer, and then we'll go over it. That's what I recommend, but do whatever the hell you want. So the answer is C. Dysthymic disorder presents with symptoms of lack of say in life and preoccupation with inadequacy. So let's quickly look over the DSM-5 criteria for dysthymia. So what we really see is depressed mood for most of the time for about 2 years or 1 year in kids, and then it's got like 2 of the symptoms of depression, and then the person never goes 2 months without those kind of mood disturbances. And then an important thing is you can't have hypomania or mania because then you'd fit into like the bipolar spectrum of diagnoses. But I should talk a little bit about MDD. So dysthymia kind of blurs the line between axis 1 and axis 2, and it kind of captures that like kind of persistent depressive personality type, but it's not considered axis 2. But you can technically have both MDD and dysthymia, and if you had both on top of each other, it would be called double depression. But because it kind of blurs that line between like a personality disorder, it's something we would expect to start pretty early. So it usually begins before adulthood. So that's why A is incorrect. It's relatively persistent in life, so you wouldn't expect it to be limited to 1 or 2 episodes like the answer in D. And then E is incorrect because psychomotor agitation and retardation, those are on the more severe end of the symptoms of major depression, whereas dysthymia is one of the less severe conditions. So you wouldn't think that's right. And then with antidepressants, there are patients who probably don't even meet criteria for any diagnoses that would benefit from it. So you wouldn't, while you wouldn't expect a major response with dysthymia, it's still possible that the antidepressants would help treat it. So that leaves us with the correct answer being C, that it presents with symptoms of lack of say in life and preoccupation with inadequacy. And this makes sense when we think of it as the blurring between, a personality disorder. So it's kind of capturing that the dysthymic patient is that chronically gloomy person with a more characterological depression. So that's why C is the right answer. All right, question 2. The person least likely to develop MDD in their lifetime is A, 10-year-old boy with dysthymia, B, an identical twin of an MDD patient who committed suicide, C, 12-year-old girl mourning the death of her mother, D, 19-year-old female who was raped 3 weeks ago, or E, a 60-year-old male with pancreatic cancer. So the answer is D, the 19-year-old female who was raped 3 weeks ago. And what they're trying to test here is that the sequelae of a very traumatic event is more likely to be PTSD more so than MDD. Looking at the other answers, a 10-year-old boy with dysthymia. So if you're a kid and you have depression, you're super likely to have depression when you're older. And then in regards to the 12-year-old girl mourning the death of her mother, that kind of reminds me of Freud's Mourning and Melancholia paper. But it's also just showing that parental loss before adolescence is a big risk factor for adult depression. All right, question 3. The defense mechanism most commonly used in depression is projection, introjection, sublimation, undoing, or altruism. The correct answer is B, introjection. And this is also a slight reference to Freud's Mourning and Melancholia. And whenever I think of that paper, I always think of the one quote, the shadow of the object has fallen upon the ego. So introjection is when you unconsciously internalize another person's thoughts or personality traits or behaviors. So if I remember correctly, with melancholia, what Freud is saying is that you internalize the negative aspects of that person who passed away, and then you attack them in your mind with like self-criticism. So that quote again, the shadow of the object has fallen upon the ego, it's really the anger that was directed at that loved one, usually unconsciously recognized, is now turned against the self. And it reminds me of, like the old quote, like rage is depression turned inwards. So it's really the negative energy directed at the self. All right, next question. Which of the following is not a change in brain function associated with severe depression? Increased REM sleep, impaired cellular immunity, hypocortisolism, increased glucose metabolism in the amygdala, or decreased anterior cerebral blood flow. So I actually wasn't 100% sure about the other ones, but once I saw hypocortisolism, I knew that was the right answer because severe depression is so closely linked to dysfunctions in the HPA axis and increased stress and increased cortisol. Quickly reviewing the sleep changes, we know we have shortened REM latency. That's kind of how quickly REM occurs. We have increased REM sleep duration and increased REM density in depression. Interesting. Who knew? Not surprised by the increased glucose metabolism in the amygdala. Amygdala is like the fight or flight thing. You get it. It kind of goes off when you're really stressed. So it's like, So yeah, not surprised by that. All right, question 5. Which of the following is not part of the DSM criteria for diagnosing atypical depression? A, shortening of REM latency. B, mood reactivity. C, significant weight gain. D, hypersomnia. E, leaden paralysis. So throwing up the criteria, we have mood reactivity is required, and then 2 or more of the following: significant weight gain or increase in appetite, hypersomnia, leaden paralysis, or longstanding pattern of interpersonal rejection sensitivity. And then a quick review, the atypical depression category of diagnosis was made because there was a subset of patients who didn't respond to TCAs at the time, and what they were looking for was to categorize the patients that weren't your typical severe endogenous depression or melancholia. So when they looked at the patients who didn't respond to the TCAs but did respond to an MAOI, iproniazide, they found that they had the absence of like the typical endogenous neurovegetative symptoms. So they didn't look like those patients that you think of with like severe depression where it's like almost like a catatonic depression, where they can't, like they're just chilling and not be able to do anything. And then they also had the emotional reactivity so that if something exciting happened, they would get excited. When someone's severely depressed and like a melancholic, the atypical type, really nothing can cheer them up. So the atypical captures those subsets of patients. All right, question 6. Reactive depression can be best compared to adjustment disorder, oppositional defiant disorder, conduct disorder, atypical depression, or schizoaffective disorder. So the answer is A, adjustment disorder. So reactive depression is defined as depression that results from a specific life event. So reactive depression isn't actually a category in the DSM. So I guess they're just kind of testing what adjustment disorder is. So I'll just quickly review. So adjustment disorder is when you have emotional or behavioral symptoms that occur within 3 months of a stressor. And there are significant impairments in functioning, and the distress is out of proportion to what you'd expect. All right, question 7. L-tryptophan is A, the amino acid precursor to dopamine. B, has been used as an adjuvant to both antidepressants and lithium. C, has been used as a stimulant. D, has not been associated with serious side effects. Or E, all the above. So the correct answer is B. It's been used as both an adjuvant to both antidepressants and lithium. So I'll go through all the other answers as to why they're wrong. So A, it's the amino acid precursor to dopamine. That's wrong. So tryptophan is the amino acid precursor to serotonin. And I kind of remember that because the mechanism of action of LSD and mushrooms are on serotonin. So remember like tripping, like, you're tripping balls. So I think of tryptophan, serotonin. Maybe that'll help. And then it's never been used as a stimulant. Tryptophan has actually been used as a hypnotic. I always remember being tired on Thanksgiving, and the mom would be like, there's tryptophan in the chicken, and tryptophan makes you tired. My mom doesn't sound like that. Sorry, Mom. And then apparently they tried to release tryptophan, but it was associated with eosinophilia myalgia syndrome. I had no idea about that. But knowing that it is the amino acid precursor to serotonin, it shouldn't surprise us that it's used conjunctively with antidepressants and lithium, kind of as, getting those building blocks in you to help with those things. So, yeah. Question 8. Common features of normal bereavement include marked psychomotor retardation, mummification, suicidal ideation, guilt of omission, or all the above. So the correct answer is D, guilt of omission. So if you remember from our Bible studies, sins of omission are when we fail to do the thing that we should do, and sins of commission are when we willingly do the things we shouldn't. So an example of guilt of omission is I should text my grandma right now and see how she's doing because it'll make her happy, but I'm not going to because I'm doing this and because grandma. But apparently what this is testing is that pathologically depressed people experience guilt of commission, so they feel guilty for the things that they've done. And then people experiencing normal bereavement feel guilt about things that they should have done, like texting their grandma. I read mummification and I was thinking like King Tut, but apparently mummification is when you keep the deceased belongings exactly as they were prior to their death, and that indicates serious psychopathology. So mess around with the dead people stuff. And then just a reminder, sins of omission and commission are sins in the eyes of God, either way. All right, question 9. Drugs that may precipitate mania include all the following except bromocriptine, isoniazid, propranolol, disulfiram, or all the above. So the correct answer is C, propranolol. So bromocriptine is a dopamine agonist. We see it used in like Parkinson's, NMS, any kind of thing that enhances dopamine you kind of expect has a risk of inducing mania. Isoniazid is used in treatment of tuberculosis. It's structurally related to iproniazid, and they actually discovered the first MAOI because they were treating tuberculosis patients and they were unexpectedly happy, and that's how iproniazid was found. But that's all to say, with antidepressants, you kind of expect risk of worsening mania. But we know that propranolol is a beta blocker, and beta blockers kind of get you down, so they can actually cause depressive symptoms. We wouldn't expect it to precipitate mania, so the correct answer is propranolol. All right, next question 10. Which of the following statements regarding mood disorders is false? A, approximately 15% of depressed patients will eventually commit suicide. B, depressive disorders are more common in women. C, incidence of depression in younger age groups is increasing. D, manic forms of mood disorders predominate in men. Or E, 1 out of 4 patients with an acute episode will have recurrence throughout their life. So the correct answer is E. So the statement that's false is that 1 out of 4 patients with an acute depressive episode will have recurrence. And what they're really testing here is that depression is a highly recurrent disorder. So in fact, 3 out of 4 patients with acute depression will get recurrence. So you should know that 1 out of 4 is a low number, so we expect a much higher number than 25%. So I'm going to stop here because I don't know if this is useful, if this is boring. Let me know if it's helpful. I'll keep going. And if not, I'll stop. So I guess thanks for getting this far.